Most common indication for adrenal vein sampling would be somebody who's got aldosterone identified by hypokalemia and elevated aldosterone levels, usually associated with suppressed renin levels. The intake is an aldosterone level, potassium level, and a renin level. And then you can calculate the aldosterone to renin ratio. Really, the imaging doesn't change the management initially, because it doesn't matter whether the patient has a mass or it doesn't have a mass, because all you're looking for is to see whether the patient lateralizes to one side or the other and is a surgical candidate versus being somebody who's a candidate for medical therapy. If they don't have a mass and they lateralize, you call that unilateral hyperplasia. And if they do have a mass, you call that a functioning adenoma. So quality assurance is really essential in adrenal vein sampling. It's best to have a single dedicated lab tech who personally takes responsibility for the samples, shepherds them through the system, and having a dedicated laboratory technologist can also ensure that, for example, if there's hemolysis, the lab doesn't discard your sample, because hemolysis doesn't affect adrenal vein sampling. We also, during our initial pause for safety, we check to make sure that the correct amount of cortrosine has infused, and so that our IV is working. The anatomy of the right-sided gland classically is like this. So a very short trunk, a descending limb, and an ascending limb. Okay, so there's not a lot of room to sample there, and that's why the right-sided sampling is the one that fails all the time, up to 70% of the time, depending on who you read. Okay. Pass this catheter up into the inferior vena cava, above the level of the renal vein, and then I'm going to turn it posterolaterally, okay, just like that, because the adrenal veins come off between 7 and 8 o'clock if you're looking at it like a clock face. Okay, and we're going to pull that down, and we're going to look for any deflection of the catheter as it comes down. And if there's any deflection, if we see it hang up like that, that's when we inject. So we don't go down injecting, we only inject when we see that deflection. Another thing we can do is we can look for the inferior accessory hepatic vein. So if we start in the hepatic veins with the catheter turned completely to the right, as we pull down, we'll first see it pull out of the hepatic veins like that, and then as we pull it down, if we see it pull into another hepatic vein, we found the inferior accessory hepatic vein. If the patient has one, and about 60% of patients have one, the adrenal vein is going to be within a centimeter of that vein. As you can imagine here, it's a very, very short configuration, so your catheter is only in a couple of millimeters. And because of this short thing, having that side hole there actually makes a big difference. The side hole may allow for, because it's on top of the catheter, may account for getting flow out of this upper limb if the catheter tip is down into the lower limb like that. But it also just allows it to flow better, because otherwise it gets up against the wall right here, and then it just can't aspirate. The other theory about the hole is that your catheter is not quite in it, magnified here, but you've got stuff flowing up like this along the back wall that you'll aspirate some of that into there. And that was the original theory, but for me, that's not nearly as important as some of the other considerations, especially on that side. You want to make sure that you're looking for that tactile feedback and that it's not coming freely. If it's coming freely, then you've fallen out into the IVC. Typically, you'll get what I call chattering, where you're getting just the vein is, the tip of the catheter is kind of banging up against the vein as it collapses and then fills and collapses and fills, and it gives a chattering sensation. We have a number of other quality assurance measures which include the timing of the specimen. Since we use a sequential technique, we always start with the right side, and then we go to the left side, and then the inferior vena cava. In addition to the labeling of the specimen for the location of the sample, we also have the time on the sample. So if there's ever a discrepancy, we can look and see whether the times look correct. Are they in the right order? On the left, you've got more typical anatomy. You've got the renal vein, you've got the common trunk, You've got a left adrenal, and you've got a phrenic. And then this is the AP trunk right here, okay? So we can sample in the common trunk, or we can sample up in the adrenal, but we always want to identify that phrenic there. We're looking for this wishbone configuration to make sure that we don't mistakenly put our catheter up into the phrenic, because if we sample there, then obviously we're not going to get it. Form it, and then we torque it so it catches on itself like that, so that it goes down through the eustachian valve. It doesn't go into the hepatic veins. And then we just use the wire to pop it back open, and then select the left renal vein. And you saw as you pull down the left renal vein, it scratches the upper wall, the cephalad aspect of the left renal vein, and usually just pops right up. This is an example of a difficult left renal vein catheterization, or left adrenal vein catheterization. You saw, but I had to kind of go in and out and in and out, and also using his respiratory motion, which straightens out and changes the angle of the renal vein to allow that to happen. So we're measuring aldosterone, cortisol, to right, left, and then the IVC, and then we're going to measure aldosterone, cortisol, and we're going to measure an AC ratio. The first thing we're going to do is, the cortisol is a control, it's a dual control. The first control is to make sure that you actually were selected, because again, you don't, the appearance of the right adrenal vein is very variable, so you don't really know that you're in it until you get the blood back, which is, then it's too late, right? And we get something that's called a selectivity index. And the selectivity index, adrenal cortisol divided by the IVC cortisol, it needs to be greater than or equal to 3 according to present recommendations. I personally use 5, but the present recommendations go for 3. The lateralization index is the higher side AC ratio divided by the lower side AC ratio, and that needs to be greater than or equal to 4 for surgery. Okay, so just to make some things up, let's just say that our cortisol is 500, and in the IVC let's just say it's 50. So our selectivity index is 10. Okay, same thing for the left. Now, this guy's got a right-sided mass, so we'll assume that this is a functional mass. So let's just say that his aldosterone from the right side is going to be 5,000. And from the left side, let's just going to say it's going to be 500. And in the IVC, 100. Our AC ratio is 10. On the left, it's 1. And for the IVC, it's 2. Okay? And then we do our lateralization index. So we take the higher AC ratio of 10, divided by the lower, which in this case is 1. The lateralization index is 10, so this patient's going to go to surgery, right? But we also look for what's called contralateral suppression, because if this gland is independently producing too much aldosterone, and this gland's not hyperplastic, it should be suppressed. So the value in the left should be lower than the value in the IVC, which it is. But you'll notice that we don't compare the raw aldosterone numbers because there might be dilution, okay? But if this was diluted and it was only say 250, okay, because of dilution here, or on the left side because of dilution because we took it from the common trunk, okay, this should also be diluted to the same amount, so this would be 2,500. So your AC ratio should still be the same, right? So that's kind of all the math of how this works.